Hello, and welcome to Lesson 2 Weekly Mini Virtual Lecture Recording. This is on Chapter 17, The Blood. Blood is the river of life that surges within us, transporting nearly everything that must be carried from one place to another within our body. In this chapter, we're going to describe the composition and functions of this life-sustaining fluid that serves as a transport vehicle for the organs of the cardiovascular system. Cardio means heart, vascular means our blood vessels. So to get started, we need a brief overview of blood circulation, which is initiated by the pumping action of the heart. This is something that we're going to discuss in during our third week or our fourth week. Okay. Blood exits the heart via the arteries, which branch repeatedly until they become tiny capillaries that service all the tissues in the body. Oxygen and the nutrients leave the blood, crossing our capillary walls into the surrounding body's tissues. The oxygen-deficient blood now flows from the capillaries into our larger veins that carry blood back towards the heart. The returning blood then flows from the heart to the lungs, where it picks up more oxygen and then returns to the heart to be pumped throughout the body once again. This cycle happens over and over and over again. Remember, this is just a mini PowerPoint so that I can verbally introduce you to the concepts of this chapter, but also please look at your more detailed PowerPoint that's under lecture PowerPoint for more information about the functions of blood and also about the components that are in the blood. Okay. So blood is the only fluid tissue found in the body. You discussed blood briefly in AMP1 when you learned about the four major tissues of the human body. One of the major tissues was connective tissue, and you learned that blood was the only liquid example of connective tissue. So what you see here, if we spin a sample of blood in a centrifuge, and you can see that we retrieved the blood from a blood sample taken from the person's arm or its vein. And we spun it in a centrifuge, and that centrifuge is going to spin the components of the blood based on its weight. So the heavier formed elements and the less dense plasma are going to be separated. Okay, so if you can see here, we have that centrifuge tube, it was spun, and this is what is going to be the result. So most of the reddish mass at the bottom of the tube will be our erythrocytes. Erythro for red, cytes for cells. So these are our red blood cells. And the red blood cells are going to function to transport oxygen, and they're going to make up 45% of our blood. And that percentage is going to be our hematocrit, which we'll talk about here in a second. It's most dense, it's the most dense out of all the other components within the blood. So this middle layer here is called the buffy coat, and this buffy coat is going to be the thin whitish layer called the buffy coat, and is present between the erythrocyte and the junction of the plasma. So this layer is going to contain our leukocytes, leuko for white, cytes for cells, and it will also include our platelets. This buffy coat made up of our leukocytes and platelets are going to make up less than 1% of the whole blood. Remember, the red blood cells made up 45%. The remaining 55% of the blood will be our plasma, okay? This is 55% of the whole blood. It's the least dense of all of the components, and the plasma is going to be the liquid component of the blood. It's the straw-colored sticky fluid made up of mostly water, solutes, nutrients, our gases, our hormones, and waste that's found in our blood, along with our electrolytes. So our plasma is the liquid component of blood, and the buffy coat and the erythrocytes are going to make up the formed elements of the blood. So the formed elements will make up 45%, and the plasma will make up the remaining 55%. Okay. So let's talk about our erythrocytes again. Remember that 45% of our whole blood is our hematocrit. So erythrocytes normally constitute about 45% of the total volume of blood, and this percentage is known as the hematocrit. Normal hematocrit values vary in individuals. In healthy males, the normal value is 47% plus or minus 5%. In females, the normal value is 42% plus or minus 5%. This hematocrit will also change in pregnant females. Okay, and as a summary, the leukocytes make up less than 1%, and the plasma makes up the remaining 55% of blood. Here you have a table showing us the composition of the plasma, the liquid component of the blood. Remember, 90% of the plasma is made up of water, and the remaining will be our electrolytes, which you learned in chapter 2 of A&P1. That's your calcium, your magnesium, your sodium, your potassium. Those are your ions, your elements that's found on the periodic table. But as we progress through more advanced sciences, we're going to those elements electrolytes. Our plasma is also made up of plasma proteins. It makes up about 8% of the plasma, and we have three important plasma proteins that are listed here. Albumin is going to be the most abundant of the plasma proteins. You can see it's 60%, and it is a major contributor to osmotic pressure. So albumin is what contains or maintains our blood volume. Okay, so it actually prevents water from leaving the blood at that capillary level. And then we have our globulin plasma protein, makes up 36%. That's going to be our alpha and our beta, which we're going to look at when we look at the composition of a red blood cell. It's the make up your hemoglobin molecule. And then we also have our gamma globulins. And then the third plasma protein will be fibrinogen. And fibrinogen is going to be important at the end of this PowerPoint. Fibrinogen is going to form fibrin, which is what's going to help make a very strong and stable blood clot to prevent blood loss. Okay. And then we have the bottom part of that table showing our nutrients that are going to also be found in our respiratory gases such as oxygen and carbon dioxide. Oxygen is what we're going to retrieve from our lungs. That is going to be the major function of the respiratory system. And then also to exhale carbon dioxide. Carbon dioxide is what's going to be picked up at that tissue level and placed back into our capillaries to go into our veins to be exhaled by way of the heart and then by way of the lung out of the body because it's waste. And then also what you learned in chapter 16, the endocrine system, that is going to be our hormones. They are transported through the blood to their target cells. So if you examine a stained smear of human blood under the light microscope, you will see a disc-shaped red blood cell, a variety of gaudily stained spherical leukocytes, and also some scattered platelets that look like debris. So this is the composition of our blood. These are formed elements that are suspended in that liquid component plasma. Okay. So here's a diagram of an erythrocyte. Erythrocyte, remember, are red blood cells. They're small cells. They are shaped like biconcave disc or flattened disc with deep centers. You can see the depressed center there. It is depressed because it is without a nucleus. You learned in A&P1 that all cells have a plasma membrane, a cytoplasma, and a nucleus. Well, the exception to that will be our red blood cells. They lack a nucleus, therefore they are considered anucleate, and therefore they also have essentially no organelles. And because of that, they are not able to reproduce themselves, go through the process of cell division or what we call mitosis. So they are going to have a lifespan of 120 days. They are going to eventually die off. Okay. So here is the structure of hemoglobin. And hemoglobin is the protein that makes our red blood cells red. They bind easily and reversibly with oxygen, and most oxygen is carried in the blood, is bound to hemoglobin. So we know that the function of our red blood cells is to transport oxygen and carbon dioxide. And this is how it's going to transport those gases, by binding to hemoglobin. Normal values for hemoglobin are 13 to 18 in adult males and 12 to 16 in adult females. And of course, this can also vary depending on if we have a female with or without gestation. Hemoglobin is made up of the red heme pigment. So what you see here is the heme, and that heme pigment is bound to globulins. We have two alpha globulin chains, the light brown here, and then the darker brown are the two beta globulins. Our heme also is going to have an iron ion. And this iron ion sits in the center of the heme that is going to help make up the hemoglobin. And a hemoglobin molecule can transport 4 molecules of oxygen. So 4 molecules of oxygen can be bound to this iron molecule found within this heme. That is how our oxygen is going to be transported by our red blood cells into our blood to our tissues. This slide discusses erythropoiesis, and erythropoiesis is going to be erythrocyte production, and it begins when a hematopoietic stem cell is going to produce a myeloid stem cell, and it is going to go through the developmental process and create a reticulocyte. A reticulocyte is what's going to be the result of the nucleus being ejected from the cell. It is considered an immature red blood cell. And over a course of a few days, it then is going to develop into a mature red blood cell called an erythrocyte. Blood cell formation is referred to hematopoiesis. Hemato means blood, and poiesis means to make. And the blood cell that's being formed in the process of erythropoiesis will be a red blood cell. Erythro for red, poiesis to make. In adults, red marrow, or our red bone marrow, is found chiefly in the bones of our axial skeleton and our girdles. Remember your shoulder girdle and your hip girdle. And in the proximal epiphysis of both the humerus and the femur. Okay, let's now discuss the fate and destruction of erythrocytes. So we mentioned that erythrocytes are not going to have a nucleus, so they will not be able to go through cell division or mitosis. So they are going to eventually die off. So they have a lifespan of 120 days. They are going to be destroyed in the spleen. Our red blood cells components are going to be recycled. Our heme is going to be degraded into bilirubin, which is a yellow pigment, This is going to be released into the blood and binds to albumin, that major plasma protein for transport. The liver cells will then pick up the bilirubin and in turn secrete it in our bowels, within the intestines, that you will learn about in the digestive system. Bilirubin will then become metabolized to a pigment called urobilinogen, and it is transformed into a pigment called stercobilin that is going to give the color to our feces. That's going to be eliminated by our digestive system. The globulins, the alpha and the beta globulins, will also be recirculated to the bloodstream. Erythrocytes disorders can be classified as anemia or polycythemia. Anemia, which means lacking blood, is a condition in which the blood's oxygen carrying capacity is too low to support normal metabolism. Oxygen is required for all metabolic processes within the body. So anemia is going to be the hallmark of blood oxygen levels that are inadequate to support normal metabolism. And individuals will usually present fatigued, pale in color, short of breath, and chilled. The causes of anemia can be divided into three groups. The first group is blood loss. The second group is not enough red blood cells produced. And the third group is too many blood cells are being destroyed. So let's talk about hemorrhagic anemia, which is blood loss. It's treated by blood replacement, so a transfusion. Chronic hemorrhagic anemia is going to be slight but persistent blood loss from examples such as hemorrhoids or a bleeding ulcer from the stomach, and the primary problem is treated to stop blood loss. Our second group that causes anemia will be not enough red blood cells are being produced. That can be caused by iron deficiency anemia, which is inadequate intake of iron-containing foods or impaired iron absorption. The second is pernicious anemia. Pernicious anemia is an autoimmune disease that most often affects the elderly. Here, the immune system of these individuals will destroy cells of their own stomach mucosa, and because of the damage to the stomach mucosa, they are not producing something called an intrinsic factor, and we need intrinsic factor in order to absorb vitamin B12 by our intestinal cells. And as a result of that, if that's not happening, you have pernicious anemia. Lack of vitamin B12 in the diet is usually found in strict vegetarians because meats, poultry, and fish provide ample vitamin B12 for our diet. And then the third example of not enough red blood cells being produced will be renal anemia. Renal means kidneys. And this type of anemia is caused by lack of EPO, and EPO is short for erythropoietin. Erythropoietin is the hormone that signals to our bone marrow from the kidney to produce our red blood cells. So if we are not producing erythropoietin, that means that we have kidney disease or kidney failure, where the kidneys are damaged and cannot produce enough erythropoietin. And then we have aplastic anemia for not enough red blood cells being produced as well. This happens with damage to our red bone marrow. When the red bone marrow is destroyed, it impairs formation of all our formed elements, which will include our white blood cells, our red blood cells, as well as our platelets. And anemia is a sign of that. For the third group, too many red blood cells being destroyed. Here, erythrocytes rupture in hemolytic anemias. Hemolytic means to lyse, destroy the cells. So our red blood cells are ruptured prematurely, and hemoglobin abnormalities as well as incompatible blood transfusions can cause hemolytic anemia. Examples for the hemoglobin abnormalities will include thalassemia or sickle cell anemia. In thalassemia, one of the globulin chains, the alpha or the beta, is absent or faulty within the hemoglobin of our erythrocytes. And in sickle cell anemia, same thing. We have an abnormal hemoglobin where we have hemoglobin S, which results from a change in one of our amino acids, the genetic makeup of the beta chain of the globulin molecule found in our hemoglobin. And therefore, we get a funny shaped red blood cell that damages the way the red blood cell will carry oxygen. So those individuals will always be in pain because of the sickle cell shape of the red blood cell being abnormally transported throughout the blood vessels. All right, and here is a normal red blood cell up top, and here is an abnormal red blood cell. It is sickle shaped, therefore sickle cell anemia, and you can see that the genetic makeup of those amino acids has a mutation here, causing that red blood cell to take on this sickle shape. Polycythemia is also an erythrocyte disorder. Polycythemia means many blood cells. It's an abnormal excess of red blood cells, or a very high number of erythrocytes that increases the blood viscosity, meaning the thickness of the blood, causing the blood to flow sluggishly through our blood vessels, and that can also lead to residual complications as well. All right, let's talk about our leukocytes. Leuko meaning white, cytes meaning cells. So our leukocytes, we have 5 types of white blood cells, or 5 types of leukocytes. The normal value for our white blood cells within our blood would be 4,800 to 10,800, or we can just say 5,000 to 11,000 would be the normal range of our white blood cells found in the blood. And of that range, we have 5 different types of white blood cells. We have neutrophils, eosinophils, basophils, lymphocytes, and monocytes. The 5 types of these white blood cells can be broken up into 2 groups: granulocytes or agranulocytes. Granulocytes contain obvious membrane-bound cytoplasmic granules, and our agranulocytes are going to lack granules. The A before the term means that they are without, so they're going to lack granules. You are often asked to list the leukocytes in order from the most abundant to the least abundant, and the mnemonic for that, to allow you to remember that, is neutrophils, lymphocytes, monocytes, eosinophils, and then basophils, from the most abundant to the least abundant. Never let monkeys eat bananas. From the most abundant to the least abundant white blood cells: neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Okay. Our neutrophils are the most abundant, with 50 to 70% of our white blood cells. And then we have our lymphocytes at 25 to 45%. Then we have our monocytes, 3 to 8%, our eosinophils, 2 to 4%, and less than 1% for our basophils. So our neutrophils, characteristically under the microscope, are going to be multi-lobed. Their nucleus is going to be multi-lobed, so you can see that there's 4 lobes that make up the nucleus here: 1, 2, 3, 4. Here there's multiple as well: 1, 2, 3, 4, and 5. So the nucleus within our neutrophils are going to be multi-lobed, and they're going to have these pale red and blue granules on the inside of their cell within the cytoplasm. Here are eosinophils. Our eosinophils are going to have also granules found inside of their cytoplasm, and you can see they're going to stain red or orange underneath the microscope. And the nucleus for the eosinophil is going to be bilobed: 1, 2. Here's our basophils. They also have granules found in the cytoplasm, and they're going to be purplish black or dark blue. And they also have a bilobed nucleus as well. Our neutrophils, our eosinophils, and our basophils, you can see that they all end in the term phil. And our phils will be our granulocytes, meaning that they are going to have a cytoplasm with granules. Our agranulocytes, meaning that they do not have granules in their cytoplasm, will be our lymphocytes and our monocytes. You can also notice that they don't end in phils, therefore they are agranulocytes. Our lymphocytes are characteristic underneath the microscope because they're going to have this thin rim of the cytoplasm showing the nucleus is going to take up the majority of the cell. And then our monocytes are going to be the largest cells of all the white blood cells. You can see that they are the largest. They also are going to have a kidney bean-shaped nucleus, a kidney bean-shaped nucleus. Right? So those are your 5 types of white blood cells. And let's talk about some abnormalities of our white blood cells. Like erythropoiesis, leukopoiesis is the production of white blood cells. It's stimulated by chemical messengers. Those chemical messengers are those hormones that you discussed in the endocrine system, interleukins and colony stimulating factors. And all white blood cells are going to originate from a hemocytoblast stem cell, just like our erythrocytes did. And they're going to have two pathways, lymphoid stem cells or myeloid stem cells. Our lymphoid stem cells are going to produce our lymphocytes, whereas our myeloid stem cells are going to produce all the other formed elements. That's the other four types of white blood cells. So our neutrophils, our eosinophils, our basophils, and our monocytes. And it is also going to produce our platelets and our red blood cells, the myeloid stem lineage. Overproduction of abnormal white blood cells will lead to leukemia. Abnormally low white blood cell count will lead to leukopenia. And leukocytosis, spelling is Leukocytosis, is an increase in the number of white blood cells in the blood, and this is usually during an infection. So now let's talk about our platelets, third component that makes up the formed elements of the blood. And our platelets are going to also be called thrombocytes. Platelets are also called thrombocytes. They are not cells in the strict sense. Rather, they are fragments of extraordinary large cells called megakaryocytes. So you can see the plasma membrane of this megakaryocyte is going to pinch off on itself, and those fragments are going to be our platelets, also called thrombocytes. Platelets are essential for the clotting process that occurs in our plasma when blood vessels are ruptured or their lining is injured. And there's a hormone called thrombopoietin that is going to regulate the formation of platelets. So erythropoietin regulated the formation of our erythrocytes, and thrombopoietin is going to regulate the formation of our platelets. Here's a summary of our formed elements. So we have our red blood cells, we have our 5 types of white blood cells, and then we have our platelets. Red blood cells are anywhere from 4 to 6 million. And our white blood cells, remember we said, were 5,000 to 11,000. And our platelets are going to be anywhere from 150,000 to 400,000. Okay. The lifespan of our erythrocytes are going to be 120 days. Our white blood cells is going to vary from a few hours to a few days to a few months or to a few years, depending on the type of white blood cell. And our platelets lifespan will be 10 days. 10 days. Okay. Let's look at the different functions of our white blood cells. So our neutrophils, they're going to function in phagocytosis of any type of object that does not belong in the body. Bacteria, viruses, fungi, galls, anything that is in the body that does not belong, it is going to eat up and destroy. So it is considered to be non-specific. Our eosinophils are going to kill parasitic worms, where you may ask, where do we get parasitic worms from? So you decide that you're going to go and take a dip in Joe Poo's lake, but you may have a cut on your foot. So there's an opening, you've broken the integrity of the membrane of the skin, and that parasitic worm that is swimming around in Joe Poo Lake has an entryway into your body through that cut on your foot. So that's where we get a parasitic worm from. We also could get a parasitic worm from uncooked pork. Uncooked pork. In your digestive system, and it is going to lay eggs and hatch into worms, and now you have worms inside of your vascular system, and therefore our eosinophils are going to go to the rescue to try to destroy them. Basophils are usually going to be the white blood cell that is released from our mast cells. They're going to release histamine and also heparin, but during an allergic reaction, okay? And then we have our lymphocytes. Our lymphocytes are going to be important in mounting an immune response to protect us from COVID-19, from the common cold, or from the influenza A virus, or B, the flu, since flu season is coming up. Our monocytes, so all white blood cells are going to circulate throughout our blood vessels, but they also are going to circulate into our tissue. And when our monocytes migrate into our tissues to protect us, they are going to then be called macrophages. And what is the function of macrophages? That is to do phagocytosis. So they're going to eat up things that don't belong in our body as well. And then we know that our platelets are going to be instrumental in blood clotting, and our red blood cells are going to be instrumental in transporting oxygen and carbon dioxide throughout the blood. Okay. All right. So now let's discuss hemostasis. Normally, blood flows smoothly past an intact blood vessel lining with endothelium. But if a blood vessel wall breaks, a whole series of reactions is set in motion to accomplish what we call hemostasis. Hemo means blood, stasis means to stop. So it stops the bleeding. Without this plug in the hole defensive reaction, we would quickly bleed out our entire blood volume from even the smallest cuts. So there are 3 steps of hemostasis. And this is a sequential cascade. The first step must happen in order for the second step to happen, in order for the third step to happen, in order for us to stop blood loss. So that first event is called vascular spasm. Here, the damaged blood vessels respond to injury by constricting or going through something called vasoconstriction. Vaso means blood vessel, constriction means to squeeze. The factors that trigger our vascular spasm event to take place include direct injury to our vascular smooth muscle. Chemicals are going to be released from the damaged endothelial cells that make up the blood vessel, and it's going to activate the platelets. Reflexes initiated by local pain receptors can also trigger vascular spasm and thus vasoconstriction. The second step will be platelet plug formation. In this step, platelets play a key role in hemostasis by aggregating, meaning sticking together, forming a plug that is going to temporarily seal the break in the vessel's wall that was damaged. Now, normally, platelets will not be sticky and aggregate together because the endothelial lining of the blood vessel was damaged. It is going to initiate a cascade of events that will trigger the platelets to become sticky. So when the endothelium is damaged and the collagen fibers of the underlying connective tissue are exposed, platelets adhere to those collagen fibers. A plasma protein called von Willebrand factor stabilizes these platelets. They become activated, they swell up, they form spot processes on their plasma membrane, and then they become stickier and stick together and release chemical messengers. Those chemical messengers that are released are adenosine diphosphate, which is a potent aggregating agent that causes more and more platelets to stick together in that area, releasing their contents. Other chemical messengers that are released from activated platelets will include serotonin, which is one of your neurotransmitters that you discussed in EMP1, and then also thromboxane A2. And thromboxane A2 is a prostaglandin derivative, meaning that it's a localized hormone, and it is going to enhance vascular spasm and platelet aggregation along with serotonin. Okay, so as more and more platelets aggregate and stick together, releasing more and more of their chemicals, more and more platelets become activated as well, creating this temporary plug. And this is an example of a positive feedback mechanism. So you guys in AMP1 talked about homeostasis, and you talked about positive feedback mechanisms and negative feedback mechanisms. This is an example of positive feedback. That leads us to our third step of hemostasis, which is coagulation. Now, the third step, coagulation, or also called blood clotting, reinforces the platelet plug that was formed in step 2. And it is going to reinforce it with fibrin. And we've already talked about fibrinogen, one of those plasma proteins. So fibrinogen is going to activate fibrin that is going to act as a molecular glue and stabilize this clot. Okay. So it's transformed from a liquid to a gel when dissolved blood proteins assemble into fibrin. And this multi-step process involves a series of substances called clotting factors or procoagulants. So this third step of coagulation is also going to have a series of steps. And here are your series of steps. Okay, so this is the third, this is going to be represented as coagulation, which is the third step of hemostasis. It's going to have its own set of events that must happen. Okay, so here we're going to activate clotting factors, and most clotting factors are plasma proteins synthesized by the liver. They are numbered 1 through 13. I'm just going to move forward so that you can see that this is coming. So they are numbered Roman numeral 1 through Roman numeral 13. They have an actual name along with that number. And you can see that most of them are produced in the liver. And you can see the pathway that they're going to take in that third step of hemostasis, the coagulation stage. Okay. So just going back, here, the liver produces these clotting factors, and they are going to circulate in our blood in an inactive state, and it's not until they're activated that they're going to carry out their function of help forming a stable clot. Vitamin K is not directly involved in coagulation. You know, vitamin K is a fat-soluble vitamin. It's not directly involved in coagulation. However, it is going to synthesize 4 of those 13 clotting factors that we saw on that table. Okay, so the coagulation sequence shows how clotting factors work together to form a clot. Okay, I know that this table can be overwhelming, but what we want to look at is how phase 1 is triggered. We want to look at phase 2 and then also phase 3. Okay, and remember that the purpose of this coagulation cascade is to stop loss. We're trying to form a stable blood clot. Okay, so activation turns clotting factors into enzymes. We're going to change the shape, and therefore they'll become active, and then they will activate the next clotting factor in the sequence, leading to a cascade. So coagulation, which is the third step of hemostasis, is going to itself occur in 3 phases. Phase 1, you see here, phase 2, which is here, and then phase 3, which is going to be fibrin being produced to stabilize this clot. Okay, so coagulation may be initiated by either the intrinsic pathway or the extrinsic pathway. Now, this is going to be determined by where the damage occurred for the blood vessel. Okay, either pathway, whether it's going to be the intrinsic pathway or the extrinsic pathway, is going to end with activating clotting factor 10. Okay, so they'll both end with clotting factor 10, and then we'll enter into the second phase of coagulation. Okay, so intrinsic pathway is called intrinsic because the factors needed for clotting are present within the blood, so it's intrinsic. This pathway is slower because it has many intermediate steps, many more clotting factors that have to be activated. The extrinsic pathway is triggered or called extrinsic because the tissue factor it requires is outside the blood. It's triggered by exposing the blood to a factor found on the cells in the tissue surrounding the blood vessel that was injured. And this factor is called tissue factor or factor 3. So you can see that this pathway starts with factor 3, clotting factor 3. It is faster. You can see that it has less steps than the intrinsic factor. So it is quicker. It can form a clot in 15 seconds. And then both intrinsic or extrinsic pathway is going to end phase 1 with the formation of a complex substance called prothrombin activator, which is clotting factor 10. Phase 2 is then begin. Phase 2 is where prothrombin activator is going to be metabolized into prothrombin. So you can see prothrombin activator is becoming prothrombin. Is going to turn prothrombin into thrombin. And thrombin will then be catalyzed in phase 3 to transform fibrinogen into fibrin. And there we're going to have fibrin strands glue the platelets together and make a web that forms the structural basis of the clot. So you can see how the fibrin strands are forming this mesh and therefore taking the liquid plasma into a gel-like and trap the formed elements that try to pass through it. In the presence of calcium, thrombin will also activate factor 13, which is our fibrin stabilizing factor that strengthens and stabilizes the clot. Okay, so that is how we form a blood clot to treat a injured blood vessel where we're losing tons of our blood volume. Okay, so fibrinolysis it's a process whereby clots are removed after repair completed. So a clot is not a permanent solution to blood vessel injury, and a process called fibrinolysis is going to remove unneeded clots when healing has occurred. Without this process, blood vessels will gradually become completely blocked. And if blood vessels become completely blocked, say for instance in our heart muscle, then that's going to lead to a heart attack. If it happens in our brain, then it's going to lead to a stroke. So we do not want these clots to stay longer than the recovery process for that blood vessel. Okay, so the critical natural clot buster is a fibrin digesting enzyme called plasmin, which is produced when the plasma protein plasminogen is activated. And it is going to cause our vessels to release tissue plasminogen activator, or what we call TPA. This is used in the clinical setting in the hospital when individuals come in with stroke-like symptoms that occurred within the last 4 hours. This is given to act as a clot buster to dissolve the clot that was causing those stroke-like symptoms and increases their chances of living, not having deficits, long-term deficits as a result of that blood being clotted. And this is our natural tissue plasminogen activator. So it plays a role in breaking up the clot. Okay. So let's talk about disorders of hemostasis. Disorders of hemostasis. So blood clotting is one of nature's most elegant creations, but it sometimes goes awry. Okay, so thromboembolic disorders result from conditions that causes undesirable clot formation, and some of those disorders can occur, such as a thrombus or an embolus. A clot that develops and persists in an unbroken blood vessel is called a thrombus. It may block circulation, leading to tissue death. If a thrombus breaks away from the wall of the blood vessel and floats freely in the bloodstream, it becomes an embolus. Okay. If that embolus is going to encounter a blood vessel that's too narrow for it to pass through, it then becomes an embolism. And if that blood vessel is found within the lungs, it becomes a pulmonary embolism. If it's found in the brain, it's going to be called a cerebral embolism. And this can cause many conditions that are detrimental. Okay. So let's talk about anticoagulant. So anti means to go against coagulation. Okay. So anticoagulation is where we have drugs that are used clinically to prevent undesirable clotting. And those drugs can include aspirin, heparin, and warfarin. And warfarin is also called Coumadin. So aspirin is an antiprostaglandin drug that inhibits thromboxane A2. So if you guys remember, thromboxane A2 was going to be one of those substances that when the platelets were activated, it was going to be released so that it can cause that stickiness. So aspirin eliminates thromboxane A2 from being released from the platelets, therefore blocking platelet aggregation and platelet plug formation. Heparin is going to be administered in an injectable form, usually in a hospital setting. And heparin is going to prevent thrombus. So it's going to be considered a blood thinner, just like all the rest of them, but it is going to prevent a thrombus from forming. Warfarin, also called Coumadin, is usually what we send patients home with, is going to reduce the risk of stroke in those with atrial fibrillation, which is a heart condition. It interferes with the action of vitamin K, and we know that the action of vitamin K was to produce those clotting factors, four of those clotting factors. So it's instrumental in preventing blood clots as well in people who are prone to having blood clots. Then we have okay, I don't know why that slide looks like that, but that slide is talking about thrombocytopenia. And thrombocytopenia is characterized by a low number of circulating platelets. And so if we don't have enough platelets, then it can cause spontaneous bleeding, okay? Widespread hemorrhage, and we can observe it on the skin as small purplish spots called petechia. And so that's what you see on the feet of this individual here. So if we were to do a blood test, we'll see that their platelets are very low in number, less than 150,000. And typically when you get petechia, they're less than 50,000. That's spontaneous bleeding. And moving on to our next topic, which will be human blood groups. People have different blood types, and transfusions of incompatible blood can be fatal. Red blood cell plasma membranes, like those of all body cells, bear highly specific molecular markers at their external surfaces, which identify each of us as unique from all others. So on the surface of a red blood cell, so you can see the red blood cells here. On the surface of the red blood cells, they have surface antigens or agglutinogens. And those are going to describe the type of blood that we have. So we have ABO blood groups, and then we have RH blood groups. Our ABO blood groups are AB, B, A, and O. AB blood type has both A and B surface antigens. Type B blood has only B surface antigens on the red blood cell. Type A blood has only type A surface antigens on the red blood cell. And type O, meaning that none are present on the surface of the red blood cell. Okay, so depending on the type of red blood cell, that is going to determine the type of antibodies that are found in your plasma, which are going to be called agglutinogens. And these antibodies that are found in the blood are what's protecting your red blood cells. So your antibodies that's found in the plasma of your blood are whatever is absent from your red blood cell surface. So if we have type AB, we know that type A and type B surface antigens are found on the surface of the red blood cell. Therefore, this person will have no antibodies found in their plasma. So that means that they are the universal recipient of any blood type because they don't have any antibodies that will attack those red blood cell surface antigens of the transfused blood. Type B is going to have type B surface antigens on the surface of their red blood cell, and therefore their antibody must be A. Type A blood will have type A surface antigens on the red blood cell, and therefore the opposite will be their antibodies, which is type B. And because type O has no surface antigens present on the red blood cell plasma membrane, they're going to have both antibody A and antibody B found in their plasma. Therefore, they are the universal donor type of red blood cell because there's nothing on the surface of the red blood cell that can be attacked by any of the antibodies in the recipient. Okay? Our second blood group will be the RH blood group, and the RH blood group is going to be recognized as a D antigen found on the surface of the red blood cell, and this is what gives us the positive or the negative in our type of blood. So an individual can be AB positive or AB negative. An individual can be B positive or B negative. An individual can be A positive or A negative. An individual can be O positive or O negative. That positive or that negative is our RH blood group. And if they're positive, that means that they also have a D antigen on the surface of their red blood cell. If they're negative, that means that they don't have the D antigen on the surface of their red blood cell. Okay? So about 85% of Americans are RH positive. As a rule, a person's ABO and RH blood groups are reported together. For example, O positive, A negative, AB positive, as I just mentioned. Okay. When mismatched blood is infused, a transfusion reaction occurs in which the recipient's plasma antibodies attack the donor's red blood cell. It is crucial to determine the blood group of both the donor and the recipient before blood is transfused. So it is important to do blood typing where we have agglutination, meaning clumping, so that we can determine that individual's blood type so that we can ensure that we're going to transfuse the right type of blood. Because a transfusion reaction can lead to death. Okay, so this is an example of blood typing that's done in the lab. So here, if we have agglutination, and agglutination is clumping, which you see here, agglutination clumping you see here, agglutination clumping you see here, agglutination clumping you see here. But however, if you look here, here, and here, there's no clumping, okay? So that is going to tell us what type of blood this individual has. So we have clumping in both the A well and the B well. So this is type AB. Here we have clumping only in the A, so this is type A. Here we have clumping only in the B well, so we have type B blood. And here this is type O because there's no clumping there. So this is how we would determine a person's blood type in the lab outside of the body to determine what type of blood to give to them. Okay. All right, diagnostic blood tests. So a laboratory examination of blood yields information that can be used to evaluate a person's health. So if you guys recall the very first slide of this presentation, we saw the individual giving blood to be centrifuged. So that same blood sample can be tested to determine the health of an individual. Okay, so microscopic studies of blood can reveal variations in the size and shape of red blood cells that can indicate iron deficiency or pernicious anemia. A differential white blood cell count can determine, can be served as a valuable diagnostic tool to see if we have high levels of eosinophils that can indicate a parasitic infection with the worm or an allergic response somewhere else in the body if basophils are high in number. A number of tests provide information on the status of the hemostasis system. So, for example, a test for prothrombin time and platelet counts will assess the ability of a blood of the blood to clot, or when we want to diagnose thrombocytopenia. And then we have comprehensive medical panels or complete blood counts that are routinely ordered during physical examinations and before hospital admissions. Here we want to determine the blood chemistry profile that measures various electrolyte levels, glucose levels, and markers for liver and kidney disorders. Together, these tests provide a comprehensive picture of a person's general health in relation to normal blood values. Okay. So this completes our blood chapter mini lecture recording. I hope you enjoyed this. Thank you and have a great day.